So the last time we met, we had talked about COVID-19. Its real name is SARS-CoV-2. Does anybody have any questions about COVID-19 before we move on? Okay. So few more topics on here with some of the more important pathogens that you might encounter with your patients. I mean, there's a lot of them, but these are some of the more common ones. And we start with the arboviruses. The arboviruses is a really great little word. And what it stands for is AR stands for arthropod. Arthropod is an insect or an arachnid, right? BO stands for born, BORNE, comes from, right? And then virus. So these are arthropod-borne viruses. These are viruses that are transmitted by an arthropod. And in Texas, the most important of all the arthropods that transmit infectious diseases, viruses, is the mosquito, right? And so you can see this one here is taking a blood meal, right? So there are a lot of infectious agents that get transmitted by these, right? So there's a list of some of them up at the top right here. Western equine encephalitis, Eastern equine encephalitis. VEE stands for Venezuelan equine encephalitis. St. Louis encephalitis, West Nile, dengue fever, and then we throw Zika in here because Zika has become a virus of interest in the United States, mostly in the southern states, because of course, the very few cases that we have had of individuals in the southern states that have had Zika. We've had some other cases of people in New York and other places, but these are homegrown Zika infections that were brought about by mosquitoes here in the southern states, mostly in Florida. But it's come up and it's got a lot of people concerned. Again, I'm telling you that influenza is a lot more serious, but nobody really is afraid of influenza, but they're afraid of Zika. Uh, Mostly, again, like, because it's affecting developing fetuses, right, and kiddos, and so when it targets that demographic of the population, a lot of people get concerned very quickly. So the one that we see most common in Texas is West Nile, although there are some cases of dengue fever, kind of Victoria South, right? So if you look, you know where Victoria, Texas is, south of that, including the the Houston area, we do see some dengue fever, and especially in the RGV, which is the Rio Grande Valley, right? Um, Down there closer to the border with Mexico, we do see some dengue fever. As a matter of fact, if people are from that area, they probably have known somebody who's had dengue fever because while not common, it is more common down there than it is um, in Austin, right? So if we think about these, and um, encephalitis is really the inflammation of the brain. Meningitis is the inflammation of the meninges, right? And so these particular viruses will attack the nervous system, mostly the brain and meninges, right? And they'll cause all kinds of problem, right? And so a lot of people will just have a very mild infection. They have a little bit of fever. They may have a little bit of a rash, but they just don't think it's serious enough to go see a physician, right? But in other cases, you can develop pretty serious infections with these viruses, including meningitis and inflammation of meninges, or encephalitis, inflammation of the brain, and they can be fatal, right? Especially to the populations that are most susceptible to these types of infections. And in this case, it's the very young kiddos up to about 10, and then the elderly, right? So 55 plus. Um, those are the demographics that are most susceptible to having really negative outcomes associated with arboviruses, right? So these are all forms of viruses that cause encephalitis, meningitis, and this is the one that we worry about the most, right? Dengue fever is becoming a lot more well known. And so you can see Aedes aegypti, right? There's the banding on the legs, right? You see for Aedes, right, that we talked about last time. It's a very aggressive mosquito. It is the known vector for dengue fever, right? And so it takes a blood meal, and when it does that, then it injects the virus into you, and over a period of days to weeks, the virus gets into your cells, nerve cells, and begins to propagate, undergoes the lytic cycle, and then you can develop fever rash. Sometimes it gets much more serious, and it can cause severe pain, muscles and joint pain. It is known as common. It's got a common name. It's called bone break fever, because some of the people will say that there's so much pain associated with it that it feels like their bones are breaking, right? It is also potentially hemorrhagic. If you get infected a second time, there's a huge immunological response, and the virus becomes hemorrhagic. And what that means is it starts to act like a hemorrhagic fever, and so it will cause bruising and breaking of blood vessels, all kinds of bad problems, right? So this is one of those things that we want to understand better, so that we can be ready if it does become a problem in Texas. Because for a long time, dengue fever wasn't in Texas. It was in South America. It came up through Mexico. And the mosquitoes don't, and the viruses don't really know where the borders are. Even there might be a border wall, and so they just come right on over. And so therefore, we have the virus here. Yeah, and it's going to be a problem in Texas, and it's going to be a problem in the South, right? So um, these are some things we'll have to deal with, right? To me, we always have these emerging pathogens, these emerging diseases. And right now, the two that I am most worried about and I have in my sights are dengue fever and Chagas disease. Okay. Zika is also a perceived problem. I'm not too worried about Zika at all. That doesn't mean it's not a serious infection, but I'm not worried about it because I'm not in the childbearing age group anymore, right? So a- the problem with this particular virus, it's been around a long time, right? It's been around hundreds of years, but it's just now getting a little bit of visibility because it started to cause problems, especially around the last Olympic. So if you remember the last Olympics, it was in Rio, and there were a lot of people worried about the problem that the area around where the Olympics were going to be, where some of the events were going to be held, were going to be in some very polluted areas, and also heavily inundated by mosquitoes, and there was a Zika problem down there, right? So, and then we started to see people in the Caribbean who were vacationing, Americans who were vacationing in the Caribbean and in South America, come home with Zika, right? So Zika, a lot of times, is just a really a mild form of, of an infection, right? People get over it and they don't even know they have it. But in some cases, it can lead, if the female is pregnant, it can lead to the blocking of the uptake of nutrients for the developing fetus. And what that leads to is the development of microencephaly in the developing fetus. And so the babies are born with microencephaly, right? And so I don't know if you can see these two infants, right? They both have microencephaly. And so what that means is that their brain and their skull were not developed properly because they were not afforded the nutrients because of the virus blocking that nutrient flow from mama to the developing fetus during those crucial times of development for the brain stem, the brain, and also the skull. And so what you have is you have this malformation of the brain and the skull. and these children are going to need assistance for the rest of their life, right? This is a huge problem in Brazil. There are a lot of infants who were born with microencephaly, and other countries also, but Brazil is the one that comes to mind. Brazil has been really hit hard by Zika and COVID, and so they're going through a state of revamping the way that they monitor and they respond to infectious diseases, as all countries should, because COVID-19 has taught us a lesson. Whether or not we continue to do that, we'll see, and we'll see how we respond to the next big pandemic, because there will be one, right? Um, but with the Zika virus, it's really interesting because it is known. Yeah, yeah. But herpes can do that too, Lakeisha, right? And we worry about herpes, but uh, we didn't worry about Zika until cases started being reported out of out of the area where the Olympics are going to be held, right? It takes these kinds of events to bring light to something that's out there, right? Because herpes can do this. Herpes is even more devastating, right? Because it can develop and infect the infant in utero, and um, yes, but I don't know the specific genus. I could look that up for you. I just don't remember the specific genus of the mosquito. Yeah. So, you know, I'm not, again, uh, uh, you know, I'm not trying to scare y'all. I am not afraid. I go out, I get, I get bit by all kinds of insects all the time. I got another case of chiggers this weekend. So, you know, you just have to be diligent, right? And so, if you are thinking about having a child in the next few years, then probably you shouldn't go on vacation in the Caribbean or in South America, right? Um, thank you, James. So, if you're thinking about having a family in the next few years, maybe you go to, I don't know, the Grand Canyon, or go to the Dakotas and look at Mount. There's a bunch of Mount Rushmore. There's a bunch of cool things you can do closer to home. And then when you have your family, then you can go do whatever you want. And also keep your husband from going to those places too, because Zika has been known to be in the semen also, so it can be transmitted through through the semen, right, through a horizontal path from the male to the female. Hmm. Yep, yep. So that's some Lakeisha, that has come out probably about 2 years ago when that first came out. Yeah, but it is true. Okay. So again, be diligent, but don't be afraid of the world. But just mitigate your risk. Okay, especially if you're going to have a family soon. Herpes is a little bit different, right? So with herpes, there's simplex one that affects the buccal cavity, the oral cavity, the mouth, right? Cold sores, that's herpes. And then there's simplex two, right, which is urogenital. And so again, this particular virus, we tend to think of it as only causing cold sores or genital herpes, right? But this particular virus can infect every single tissue of the body. It can cause encephalitis, yeah. Um, it can cause all kinds of other serious infections, right? Um, but people don't know that, or people don't think about it, right? But you can see that it can infect the eyes, it can infect the nervous system, the brain, the kidneys, just about everything. And there have been cases of um, of fetuses in the uterus who have contracted herpes from the mama, kind of again a horizontal path from the pregnant female to the developing fetus, and a lot of those babies are born still, right? They're born not viable, and a lot of times, yeah, they're just completely surrounded with lesions from herpes, right? And so again, this can be a real serious infection. We tend to only think about it as causing cold sores and sexually transmitted infection lesions on the urogenital area, but it can be much more serious than that, right? So, any questions about herpes? We move into our last virus, which is a really important one, which is the HIV virus, right? The human immunodeficiency virus, which causes the syndrome, the series of symptoms and signs that we know as AIDS, right? And so to me, this is a very diabolical virus. All viruses are pretty interesting to think about, but this one is of particular interest because it is biologically designed to only infect one type of cell. It will only affect the CD4 helper or the T4 helper. Now, the T4 helper, its function, its responsibility in the body is it is the sentinel for the entire immune response. So when it gets communicated that there is something in the body that doesn't belong, it has the power to turn on the rest of the immune system, right? And we haven't talked about the immune system yet, but we will. But this little beautiful cell in our body, the T4 helper, turns on the immune system, right? Well, the HIV virus only infects that cell and it takes it down and it brings it down to numbers that are way below what we need in order to be protected. And so at some point during the infectious process of the lytic process of the HIV virus, we become immunocompromised. People do not die of AIDS, they die of an AIDS related opportunistic disease. And that's what killed people, right? So here in this top image, you're seeing one of the first um, electron micrographs showing a T4 helper, and the little green structures are the HIV virus, which are getting and infecting the cell itself. Right. When it does that, again, it takes over. It takes over the cell's machinery, the cell's biochemistry. It uses an enzyme called reverse transcriptase to actually build more viruses using RNA as a template because it's an RNA virus. And then therefore DNA is made and then new viruses are constructed and they get released and then they go out and they infect other T4 helpers, right? And so at this point, um, you're into the process of uh, of being hugely infected by HIV. But that doesn't mean you have AIDS yet, right? So when we talk about HIV and AIDS, if you're HIV positive, that just simply means you've been exposed to the virus and you carry the antibodies against it and you test positive for the antigen, right? The antigen is, of course, the thing that doesn't belong in our body is the HIV virus, right? Now, you can be HIV positive for a long period of time. You may, as my friend is, have HIV but never develop AIDS, right? Um, and so I may talk about him a little bit later on in a little bit more detail. But if we think about then the progression of the infection, so a lot of times after having HIV positive, you can take a cocktail, and we'll talk about it in a little bit, and it will keep you from developing AIDS. If you don't know or you don't have the resources to take the cocktail, then the virus continues to grow in your body, and eventually your numbers of T4 helpers get below um, a certain number, right? And so there's some um, people who say 350, right? Others say 200. And so I'm going to be more conservative and just say 350 at this point. Um, but there are people who say 200, right? And so that's less T4 helpers per microliter of blood. But I'm just going to say 350 because that's more conservative, and we'll just call it then. Once you have been diagnosed, have been confirmed to be HIV positive, you've had your numbers of T4 helpers go below 350 per microliter, and you develop some infection or some cancer or some other disease that we typically don't see in healthy individuals. right? These can be things like toxoplasma causing encephalitis. It can be cryptosporidium causing chronic diarrhea. It can be Muscis vecchi causing pneumonia in the lungs. These are all organisms that typically, in a healthy individual who's immunocompetent, has a good immune system, that they might come down with a slight infection of these organisms, but never really develop into a chronic or acutely serious infection, right? So our AIDS patients, once you have been diagnosed HIV positive, your T4 helper below 350 per microliter, and you've had some type of opportunistic disease, right? An older term for that is ARC, an AIDS related complex. Almost nobody uses that anymore, but I put it there because sometimes other older people do use that, but it's really this opportunistic infection or things like Kaposi sarcoma, which I'm going to show you in just a minute. If you have these three things, right, you're HIV positive, your T4 helper is below 350 per microliter, and you've had opportunistic infection or a disease, cancer, then you are an AIDS patient, right? And so some of the opportunistic disease you can get is encephalitis, meningitis by these viruses that or these parasites that we just don't really have a problem with, right? You can get retinitis, right? So infection of the retina can cause the blindness. Remember, I told you that toxoplasma is kind of trending with causing blindness in patients, right? You can get pneumocystis, pneumonia, tuberculosis in all different kinds of organs. So people don't know this, but tuberculosis is not just an infection of the lungs. It can infect every single tissue of the body, right? Tumors, skin tumors, this is Kaposi sarcoma here. So we never used to see this form of cancer except for certain ethnic groups, right? Italian men in their late 50s, we saw this, but now we started to see it in young folks, you know, 19, 20, 20 up to, up to 30. We started to see this cancer, and we didn't know what it was at first, and then we started doing a lot of research and found out it was KS, right? So esophagitis by candida, right? So it causes an overgrowth of the organism in the esophagus, right? Sparsely populated, and there's nothing there, but now you have this yeast that's growing throughout it, and it's really interfering with our ability to take in nutrients, right? Chronic diarrhea by cryptosporidium, and then tumors just about everywhere. This is wasting disease here that's being portrayed by this patient right here. And wasting disease in humans is different than wasting disease that we see in animals because of prions, right? But here you can see wasting disease is the person is so sick that they don't really want to eat anything, and the body turns on itself and starts to digest its own proteins, and so you can see that they're just simply wasting away because they just don't have either they don't have the ability to consume nutrients, or um, they may just not want to eat, right? So another terrible thing that we deal with our AIDS patient is that they're 1,000 times more likely to have suicide ideology, right? Because they're dealing with this terminal illness that they know is going to be terminal, and they don't see a way to allow them to live a healthy, normal life, right? Yeah. So this is a really serious infection, and even though you might live with it for years, at some point um, it will rear its head, and you'll have to deal with it. At least, at least that's the current thought, right? Magic Johnson, for those of you who know, he's a very famous basketball player, and he's HIV positive, but he is um, a very wealthy individual. So he's got a big business empire now, and he has his own physician that travels with him. He has his own nutritionist. He has his own personal assistant who makes sure that he takes all his meds every whenever they're supposed to be taken. And Magic Johnson, is a really healthy individual. So And he kind of did a little bit of a disservice to everybody when he went on one of the late night talk shows and basically said he was cured. And what he really meant was that the viral load of HIV in his body is so low it's not detectable anymore. But that doesn't mean you're cured, right? That just simply means that the medications, the antivirals that we're giving them, allow them to knock that viral load so low that it's not a problem, right? So this cocktail really consists of three different antivirals. One of them they all do different things. One of them might attack an enzyme system, right? Reverse transcriptase. One of them might infect the ability of the virus to get into the cell, the T4 helper. And one of them might block protein synthesis of the viral nucleic acids so that no new viruses can be made, right? So you take these three drugs in combination and you can live a normal, healthy life for a long period of time. But the current understanding is that yeah, that's right. That's right. So the current understanding is that at some point the cocktail just doesn't work anymore for whatever reason, right? And so there are lots of different names. I'm going to ask you to know it as HAART, HAART. There are lots of different ways to talk about this, right? But I think let's just use this one. And that way, when I ask you questions about it on the exam, you're going to know that HAART stands for highly active antiretroviral therapy, right? And so I want you to know this term. You might be given a different term in pharmacology or a different acronym, but this is a good one, and it's easy to remember. HAART, right? HAART, highly active antiretroviral therapy, right? And so there's lots of ways to talk about it. I'm going to show you some of the other terminologies that we use to talk about the prophylaxis and the post-exposure therapies that we have for this. But this is a serious infectious agent, right? And the thing about this particular virus is that you never have to get exposed to it, right? So again, you mitigate risk, right? If you really love somebody and you want to spend the rest of your life with it, the thing that you should the thing you should do responsibly is to go and get tested for sexually transmitted infections before you start to engage in sex. Now, that's not going to happen very often, right? Because that goes to trust issues or things like that. But to me, it makes a lot more sense, and it would really build up trust if both of you would go together and get tested together and then share the results for each other. That would bring a lot of openness to the relationship. That's just not the way we act as humans. Are you with me? So that's unlikely to happen. But this is a really great advancement. Now we still don't have a cure for it, right? Now I will tell you that there was an individual in Germany, and I can't remember his name. Timothy Ray Smith comes to my mind. Maybe James, maybe you can look it up real quick. But this individual was cured of HIV. The problem is he also had some other forms of cancer, and they were doing a lot of therapies for the cancer along with the therapies for HIV at the same time, and some combination, some synergy between. Okay, thank you, Timothy Ray Brown. So some combination of the synergies between the drugs they were using for HIV and the drugs they were using to fight the cancer worked together, and it got rid of the virus, right? They couldn't find it. They haven't been able to find it. He hasn't taken any other therapies, and he hasn't shown to have the virus anymore at all. So at this point, it is a medical, scientific, clinical advancement, but a mystery because we can't replicate it, right? And so there's individuals doing research to try to figure out how to do that, right? And and so it was an amazing thing. There was reports of another individual who um, who was cured, but then it was retracted because he came down with an opportunistic disease, and so it was retracted. But Timothy Ray Brown, thank you, James, is the individual who we believe was cured from HIV from that synergism that happened between all those different therapies he was taking, right? So here's just another word, right? Combination antiretroviral therapy, right? Or antiretroviral therapy. There's just a bunch of them. We're just going to use HART, okay? So here's some of the drugs. I'm not going to go through them all, and I'm not going to expect you to know them, right? But if you think about them, right, they are things that can do all kinds of inhibit all kinds of different processes with the virus in the way it either gets into the cell, leaves the cell, proteins are made for it, the way that the nucleic acids are made for it once again. So there's so many different ways that you can do this, and it's a combination of 3 different drugs that are used in order to treat the patient. It's treatment, right? It's not a cure, but it's treatment, and because of that, lots of individuals who have AIDS, who have HIV, never develop AIDS and can live a really great life, right? Yeah, it's pretty cool stuff, right? Still, we do not have a cure. Okay, so I've talked about this already. So PrEP and PEP, right? So these are pre-exposure prophylaxis and post-exposure prophylaxis, right? They're a little bit different, right? Pre-exposure prophylaxis, PrEP, is what's being used right now, and you might see these advertisements for it on buses, and sometimes they're billboards that are showing individuals who say things like, I am making sure that I am not going to contract HIV for whatever, I'll say something or whatever, right? But to me, PrEP has become one of these things that now certain populations will use as kind of a get out of jail free card if they believe that if they take this drug or this combination of drugs that they're never going to get HIV. It's not 100%, right? And if you miss a day of taking the prophylaxis, then you're more susceptible to coming down with this infection, right? I had a student who asked me to talk to her brother because her brother was younger, right? And he was he was being he was being very irresponsible, and she knew it. And so I talked to him about what he was doing and what it could lead to. And the sister was with me, right? Sister and her brother and I talked about this. And then I told him that he said, "Well, I'm taking PrEP." I'm like, "But," I said, "that's not 100%." But anyway, he 2 months later, his sister came to me and said, "Thank you, but I want to let you know that my brother is HIV positive now." And so it's not 100%, right? And so people think it's 100%, and it's not, right? It's prophylaxis, right? It was intended to be for people who are in a monogamous relationship where one of the individuals had HIV and the other one didn't, right? So that if this couple loved each other, that one of them could take PrEP not and minimize the chances that they would develop or be positive for HIV. But that's not what it is now. It has become kind of this a freedom, get out of jail card free, where individuals who are exploring their sexuality are taking PrEP, and not just homosexuals, but but everybody, and they're using this as kind of I'm just going to experiment with whatever I want to do, and then to me they're just really not being very responsible. That's not what this drugs are about, right? PEP is post-exposure prophylaxis, and so if you engage in sex with somebody and find out that they're HIV positive, you can take the post-exposure prophylaxis, and you take it for 28 days straight, and hopefully it will not allow the HIV virus to become a problem with you, right? And so again, that's oh hell, I've been exposed to HIV. What do I do now? Well, let's just pray and hope. No, you need to go and have PEP, post-exposure prophylaxis, and hopefully you won't have those problems, right? And then we talked about heart, right? Heart is that thing that you take um, for life, and it will not allow you to develop AIDS, right? You can be HIV positive, but you will not develop AIDS. Is there any questions about HIV, AIDS, the definition of being HIV positive versus the definition of being diagnosed with AIDS, the differences between PEP, and heart? You guys got all, because it's going to show up on the exam. Okay, questions? The last thing that we'll do before we go on to talk about the determinants of health and disease is really briefly talk about prions, right? So prions are infectious proteins, acellular, and so these things have been around for a long time. Um, the Most people will know them as causing mad cow disease, right? And mad cow disease is the common name for what we know as bovine spongiform encephalopathy, right? And also um, we have TSE, right, which is transmissible spongiform encephalopathy, right? So this is again bovine spongiform encephalopathy. That's mad cow disease, and then if you just put a T in front of it, transmissible spongiform encephalopathy. That's what we typically see in humans, and that includes everything like Kuru and Creutzfeldt-Jakob disease and the variant form of Creutzfeldt-Jakob disease, a whole bunch of different things, right? So this is a problem. Nobody's really doing a lot of research on it because it's not really affecting very many humans, but it's out there, and it's infrequent. We're seeing it more commonly in our deer, antelope, elk, and moose populations than we are in any other group of organisms, right? And we believe with them, it's just the exchanging of saliva is how they acquire this infectious protein. With humans, we believe that you can get it through transfusions or transplants of organs, but also we believe that you might be able to acquire it through eating contaminated meat. And so the science is still a little fuzzy about how humans get it. We know that you can get it from transfusions, from atratogenic processes, like operations and things like that, right? Um, and we know that you can get it from eating contaminated food, right? Meat that's not cooked all the way through, or at least we think that. But we still don't understand why it only affects certain people. What we know is that almost everybody has some prions in their body, but they never manifest themselves as disease. Some of them do. Um, but why? We have all these questions about what's going on with these infectious proteins, but very few people are doing research on it because it's not affecting the human population very much. And so therefore there's not a lot of money put into it until we're not very smart like that, right? The human population not very smart. We wait until something is a problem before we start to try to figure it out, where we should see that this is going to be a problem in the future and we should start studying it now, but we just don't do that. We're just not very good at that, right? So we don't know how to kill it. We don't know how to, or I'm sorry, it's not alive. We don't know how to inactivate it, right? We tried sterilizing it in an autoclave for 90 minutes at 15 pounds per square inch for at 121 degrees Celsius, right? And it didn't work. So we just don't know, right? And it's going to be a problem. And I don't know what to do about it. For a long time, I always worried um, that the prions wasting disease would become a problem in our deer population. And so I worried about it for about 15 years. And then 3 years ago, it finally happened. And we started to see prionic disease in our deer population right a little west of San Antonio, and in the Uvalde area. And so A&M is set up with Texas Parks and Wildlife to be kind of the research central. And so Texas Parks and Wildlife does give an update about where we find prionic disease in Texas, but nobody really pays attention to it. They continue to do what they want to do because, we're Texans. We're not worried about that right now, right? If you traveled to the UK or France in, I think it's year 1999 to 2002, you will never be able to donate blood. And so that's one of the screening questions they ask you when you go and donate blood. They'll ask you, were you in what we know as the United Kingdom, right? Great Britain, Scotland, Ireland, um, Northern Ireland, or in France during the years of 1999 to 2002. And if you answer yes, you're automatically disqualified from donating blood because there was a huge mad cow disease outbreak in that area of Europe in that time frame, right? And so it's just one of the ways that we mitigate risk. Yeah. Yep. And so not only that, what was really scary to me, Miss Mercy, is that all these proteins have to do to replicate is to bump into other proteins, and they cause a conformational change, and those other proteins and the other proteins that they bumped into become prionic by nature. That's the scary part. Yep. Any questions about prions? Ladies and gentlemen, that is the end of the material for exam 3. Exam 3 will be on Wednesday, and we'll have a review for it after our lab today. Okay? Any questions about anything we've talked about as of yet? Okay, unit 4, here we go. Right, so determinants of health and disease from a microbiologic, from my perspective, from a microbiology perspective, right? And so I like to learn. I am always in school some way or another, right? I'm finishing up a dissertation right now, but I went to a meeting in the spring to look at COVID-19 and some of the work that was being done. This gentleman right here is the guy at UT who did all the research on the spike proteins. This guy right here. He is a really great scientist. He did all the research for the spike proteins, which allowed us to develop the vaccines. I was in my element, right? So you can see all of my questions, right, to all these people. And I was asking this guy from UT all kinds of questions about his research. You can see these are questions for me to these individuals because I was in my element. They were talking the science that I love. And so I wanted you to understand that I am trying all the time to bring you all the best information that I can when I talk about these things, right? So that I don't make mistakes and that I am current on everything I do. So I go to school like once a week. I take a 6-hour class on a weekly basis and just to update myself to make sure that I am up on things, right? And so this is me going to school, and you should be a lifelong learner also. I want you to go to school forever and learn forever, right? And so that's my wish for you. Well, when we talk about what determines good health, right, there are 3 different scenarios or 3 different things that we look at, characteristics, right? Good physical health, right? And there's lots of parameters there, right? We can look at things like blood chemistry. We can look at BMI, which is not a really good indicator, but people use it, right? There's all kinds of. We can look at your blood pressure. We can look at forever, right? Mental health. So I am not an expert in mental health, right? But there are, I think 20% of the American population has some type of mental challenge. And so there are lots of parameters there. I just don't know them because that's not my thing. But there are people who are really good at trying to figure out whether or not somebody needs some help because of a mental challenge. And then there's spiritual health. And spiritual health, a lot of times people will kind of equalize spirituality with being religious, and that's not really what this is about. You can have spirituality because you're religious, but really spirituality is about what makes you a person in the world. Why are you here? What are you doing for the world, right? And that might be that you have a kiddo, and you are all in and making sure that kiddo has a great life. That's your spirituality. It might be that you are helping the homeless, and so you have this garden like my friend does. She has this garden that is a community garden with some other people that have chickens, and they collect eggs and all kinds of fruits and vegetables, and then they donate the fruits and vegetables to the homeless or to the food bank. They sell their eggs to raise money for the homeless. They do a lot of things, right? So there is a lot of research out there that basically says if you have a purpose in life, if you have a reason to get up in the morning, right, that you're going to be a lot more positive, optimistic, healthy, all kinds of things. Have you ever heard of an individual who has cancer, and the people who are treating, the nurses who are treating them, are trying to lift them up to try to make them more positive, because it has been proven that if an individual uh, thinks they have a chance, they are hopeful, then they really have a chance, because their bodies will produce certain types of molecules that will help them with trying to fight off whatever disease they're trying to fight off. Right? Yeah. You could see that with my father, that he was very hopeful at the early parts of his treatment for cancer, but in the end, he just gave up. And once they give up, they go pretty quickly. Yeah. So my father, once he gave up, he had passed away within 2 days. Once he just gave up, and it was just too painful for him, and so he couldn't, gastric cancer. He just couldn't deal with the pain anymore, and even the morphine drip wouldn't help anymore, and so he gave up. Right. There's a lot of things that we look at that goes into the health of an individual, right? So look at all these things that go into it, right? So it's not just about getting an infection, but it's about being exposed to that. Why were you exposed to that? What was the cultural reason you were exposed to it? What was the social aspect of the interaction? What was the um, what was the medical status, or the health status of you at the time you got exposed? You have to think about all these different things, right? And so because of that, we can put these things into kind of this area of what factors can affect health. And again, it's not just infectious disease, although that's my thing, right? It can be all these other things, right? But really, when you think about it, the one thing that really drives um, disease and infection is really the social economic factor. And so that's the big thing that we're trying to bring about, is really education. And it's not education necessarily about going to college, although that's important in my mind, but it's about education and helping the individuals understand why they should follow their treatment plan, why they should take their meds when they need to, right? Because if you do those things, um, then you can um, then you can get away from that cycle of not being healthy, right? And so my family in Corpus is a very unhealthy group, right? They eat whatever they want. They drink soda and all these sugar things all the time. And so um, I am not a skinny person, but when I go to Corpus Christi, Texas, I am a lean individual compared to the other people that are in my family, right? And um, and so that's one of the things I've been trying to work on, right? As we get closer to getting back to, because this is all kind of interwoven with why certain individuals come down with infections, right? And think about all the people who got COVID, right? The vast majority of the people who got COVID were those individuals who, number one, couldn't work from home. They had to go and do their work at a place, right? They were in the service industry or something like that. And so, that stems from, what kind of opportunities are available for individuals based on their skill sets, right? And so this is why it's important to have a skill set, right? I'm not saying you have to go to college, but man, learn how to be a plumber, learn how to be a carpenter, learn how to be an auto mechanic. Those are all skill sets that are important, right? And where I am definitely not an auto mechanic or a tractor mechanic or a lawn mower mechanic. When I have the skill set to fix those things, I will do it myself because it's a lot cheaper, right? Yeah. So when we talk about the interaction of the infectious agent with the human, that's the aspect I'm interested in. That's one of the things I'm interested in research. I'm interested in using education to make sure individuals understand why they are seeing a lot of individuals like them come down with infections, right? The, the two groups of individuals that we are seeing the highest incidence rate, the highest number of new cases for HIV and AIDS is young Latino women, right? Young Hispanic women. And so why is that, right? Why is that happening now? And so, there's a group of individuals who are doing a little bit of research, and I'm trying to tag along with them to try to get into some of that aspect of why that's happening, because I want to figure out a way to use education to help to let those individuals become knowledgeable about how they can limit their exposure to these pathogens, right? So we look at these terms: pathogenic, opportunistic, pathogenic, virulent, right? Pathogenic is an organism's ability to cause disease. An opportunistic pathogen is an organism that is typically with us and doesn't really cause us any problems. Could be a commensal or a mutualistic organism with us, but then given the right opportunity, then can cause a disease or infection. E. coli is number one. It's the number one cause of urinary tract infections. E. coli is. And usually E. coli on our skin is not a problem, but if it gets into the urinary tract, it can be a big problem really quickly, right? And so we want to understand how we can intervene so those kinds of things don't happen, right? And then virulent, of course, is any organism that has a high degree or capability of causing infections, and that's because of some of the factors that they have associated with them, right? Because of the genes that are in their chromosome, right? And we're going to talk about those things. I mean, we call those things virulence factors, right? So if we think about virulent, right? So there's E. coli 0157H7, right? And then there's an E. coli that's in my gut. Well, which of those are pathogenic, right? So both of those are pathogenic because they have the ability to cause disease or infection, right? But E. coli 0157H7 is more virulent than the E. coli, the run-of-the-mill E. coli that's in my gut, right? So that particular organism is a true pathogen, and in 20% of the individuals who get exposed to it, it's going to cause hemolytic uremic syndrome, right? Which is a real serious infection. Hemolytic uremic syndrome. Okay? So that means it's in the blood, it's affecting the kidneys, and it has a lot of signs and symptoms associated with it. Right? Be serious. 20% mortality for the individuals who get exposed to that. 20%. That's high. Don't like it. Right? So we need to be careful about understanding how we can better our world by helping our patients, our friends, our colleagues to be be knowing, right? Portals of entry. Portals of entry are how the organism gets into our body, right? And so they're typically four major pathways, right? Skin, right? Break or breach in the skin. The skin, it's pretty good covering. It's a pretty good protective layer. And if it's intact, very few things are going to penetrate it. Okay. But if you get a break or a breach or a scratch or a rash or whatever, then things can get it. Mucous membranes, another way, right? The placenta, this is from developing fetus and mama, right? And then the parenteral route. So this is usually when we talk about parenteral, the true definition of parenteral is any way to deliver a medication through mouth. When we use it here in microbiology, looking at how organisms get into the parenteral route, it's kind of the same thing, but mostly because we don't use interthecal or interoptic or things like that, like some of the drugs might be delivered. We typically talk about intravenous, and so this is individuals who are using intravenous drugs, right? And when they're doing that, they're sharing needles, and it's a way that infectious diseases like HIV can get into the body. What a lot of people do not know, I'm sure you've heard of the opioid crisis in the United States, right? So, secondary to the opiate crisis and being facilitated by the opioid crisis is the crisis of HIV. By sharing those needles, individuals are acquiring HIV at a lot faster rate because they're sharing needles to get those narcotics into them, and they also are putting HIV into each other when they're doing that. And so several groups tried to help um, because you really have to have a lot of treatment and a lot of sequestering and a lot of things have to happen to these patients to wean them off of the opioids. You just can't go and say stop doing it. They won't be able to. So some groups that I know were going in Kentucky and Tennessee and that part of the world, and they were giving free needles and syringes that were sterile and clean to these individuals so that and they asked them to please, if they were going to do this kind of behavior, they were going to use injection to make them feel better, that they please use a clean needle, right? They set up little needle boxes where they could put the needles in afterwards, and they would come over and they would pick them up and they would get them to be destroyed properly, and they made it so that you couldn't go in there and get the needles out of there. So they would change them out every few hours. These are all volunteer people, and the local governments of the two cities that they were working in stopped them from doing that because they said that they were um, becoming enablers to individuals who were taking opioids, right? And while that might be true, the reason that they were doing that was so that on top of being an addict to um, opioids, that they wouldn't develop HIV or hepatitis B or Hep C or some other bloodborne pathogen, right? But so you can see, that there's always going to be this kind of friction between people who want to help do some good for the community and other people who are more believing that it's up to the individual to do good for themselves, right? And so that's the problem that we have with a lot of social issues, right? And we can't solve them all, but we can do what we can. Okay. There's a difference between contamination and infection, right? So contamination means that there's an organism or a virus that's on a surface, right, or in a liquid. Your your bottled water can be contaminated with E. coli, right? But that doesn't mean that you have an infection. An infection really means that the organism gets into your body, it starts to grow, right? Once it starts to grow, it starts to do things to the body, which then causes the signs and symptoms of the infection, right? But in order to have an infection, you got to have an organism involved, and the organism has to be affecting because it's in the body, right? Contamination is not the same thing, right? Your skin can be contaminated with E. coli, but that doesn't mean you have an infection, right? If E. coli gets into the bloodstream because there's a break in the skin and it causes bacteremia, then that's a different story. But usually when we talk about, I've heard people say things like, my cutting board is infected with salmonella. Well, that's not true. Your cutting board might be contaminated with salmonella, but it's not infected. It's an inanimate object. It really can't be infected, right? It can be a reservoir. Um, it can be contaminated, but it doesn't mean that is an infection. Okay. So the skin is this really beautifully structured tissue organ, right? It's the largest organ in the body. And for the most part, it's going to stop almost everything from getting into your body. It's a really great barrier. There are a few things that can penetrate the skin and get into the body directly, but they're very few, right? So for the most part, if the skin's intact, you're protected. That's a good thing. Okay. And I'm not going to talk about the different layers of the skin because you've had anatomy and so you know, but infections can happen superficially, right? And it can happen in middle layers, and then it can happen throughout the entire structure of all the integument itself. Okay, the mouth. This is a very beautiful mouth. The two things that I notice about people very quickly when I meet them is I notice their mouth, and it tells me a lot about the individual and how healthy they are, but also, how well they take care of themselves. And then a lot of people wear sandals or things like that. I noticed feet also, right? Feet tell me a lot about a person also. Now, I don't think I'm judging people. I just think that that's just as part of my training. Just thing that I always look at, right? And so you can see here that this mouth is really a beautiful mouth. Yeah, maybe the lips are a little dry, but I mean, look at the mouth itself, right? It's beautiful. There doesn't appear to be any inflammation. Look at the gums and the teeth. The gums and the teeth. The gums are really tightly, real close to the gums. They're not red. They're nice and pink. Uh, it's a beautiful, beautiful mouth, right? And so to me, this would be that's the way I want my mouth to look whenever I see the mouth, right? But this particular thing uh, is it it's the way we kind of come in contact with the world, right? So we drink things, we smell things, and smells also involved with the mouth. Um, we eat things, we put things in our mouth. So we do all these kind of things, and um, it's the way that we kind of interact with the world, right? Not only the eyes and the ears, but also our other senses to smell and taste, right? Dogs, on the other hand, they're mostly about smell and about taste. So if you ever watch a puppy is going to put everything in its mouth, right? It's going to chew on it because it's trying to figure out what it is. And so that's the way a puppy deals with it and knows what it is, right? And so if it doesn't taste good to it, the puppy's never going to put that in their mouth again, right? And so that's why um, when our dog was she's gone now, she's passed, but when our dog was a puppy, she tore up probably 3 water hoses because she was trying to figure out what they were, and we lost 3 water hoses because of that, right? So it's a portal. Lots of things can get in there because we do lots of things, right? So here is kind of organisms kind of moving from mama to developing fetus, right? So you can see some of these organisms. You will not be responsible for this table, but I just wanted to show you how it can affect the embryo. So Toxoplasma gondii can cause abortion, but it can cause lots of other problems, right? Including microencephaly, right? So we're worried about Zika, but why are we not worried about herpes causing microencephaly? It's more common than Zika. Why are we not worried about it, right? Yeah, because of the way it's been portrayed by different people, right? So here you can see bacteria, syphilis, and listeria, right? Here's DNA viruses like cytomegalovirus can cause deafness and microencephaly. Again, microencephaly, man. everything infectiosum by parvovirus, right? And then RNA viruses like HIV and the Ruby virus is German measles, right? People aren't worried about German measles. Why? Because we haven't seen it in the United States for a long period of time, but we're seeing it in Europe again because there's a huge anti-vax movement in Europe right now, and I just don't know how we're ever going to get people to believe in vaccines again. That is right. That's rubella. Mm-hmm. Yep. Okay. So what's the difference between a disease and infection? There are infectious diseases, but when we talk about diseases or things like cystic fibrosis, cancer, diabetes, cardiovascular heart disease, mental illnesses such as depression, alcoholism, yes, alcoholism is a disease, right? But being addicted to narcotics is not. I don't get it, but okay. That's the insurance company and the power of the insurance company, right? And autoimmune diseases like lupus, right? So these are all going to be they're all going to be associated with some type of dysfunction, right? Either host tissue like arthritis or some other metabolic process like diabetes or hyperglycemia, right? So that's a disease, right? This is scoliosis, and then everybody knows about Muhammad Ali, Cassius Clay, about his bout with Parkinson's, right? People say he had dementia, but he didn't really have dementia. And you might be saying, well, Provi, how do you know it? Well, because a friend of mine that I grew up with, Ricardo Reese, is a very famous artist. And Muhammad Ali um, would come over and buy his art. And so one time I got to meet him. And he was sharp. The dude was sharp. He took a little bit of time to answer you, but he was sharp. He could tell you exactly what things meant, right? Sharp. So to me, he didn't have dementia. He had Parkinson's for sure, but that's because of all the trauma that he had from being a world-class boxer, right? For as many years as he was, right? Infections, if you look at them, right? Cellulitis, sometimes known as pyoderma, right? Uh, Pharyngitis, conjunctivitis, pneumonia, also known as pleuritis, cystitis, otitis media, vaginitis, colitis, gastritis, encephalitis. These all end with itis at the end of it, and that means there's inflammation. And the inflammation is due because there's an infectious agent, a microbe, that is interacting with the tissues or the metabolic processes, and you're having this inflammation, right? So there's a big difference, right? So you guys have heard me use the term etiology, and I like the term. You will hear me say it a lot more toward the end of at this portion of the course, because now we're talking about the interaction of the infectious agents with the human host, and when we get to unit 5 it's going to be all infection, right? And so etiology is the study of causation. Now everything can have an etiology, right? So cancer can have an etiology, and it might be that people were exposed to gasoline a lot. But when we're talking about infectious disease, we're really looking at what is the etiology, what is the cause, right? And so it's important that we understand that. We like to talk about diseases in lots of different ways, right? And so I'm going to ask you to know these terms for the exam, right? I don't need you to know all of them. I just need you to know starting with immunological and then going down. I need you to know those terms, right? So immunological, right? This is the immune system, right? You can have a hypoactive immune system and therefore it doesn't function properly, or you can have a hyperactive immune system and then it overreacts, anaphylaxis, right? Neoplastic, that means tumor, right? That means cancer. And you'll be might be surprised to know that a lot of cancers are caused by infectious agents, right? And we'll talk about some of these. Infectious, right? Caused by an infectious agent. We're going to talk about the infectious process in just a minute. Atritogenic, I brought that word up earlier when we were talking about prions, and I said, um, uh, it can be through an atritogenic process. This is anything that is medical procedure on you, right? And so an operation or whatever, and then you have the infection being kind of spread from that, either that treatment or that process, right? Idiopathic is another great word, and you're going to hear it a lot. Idiopathic means we don't know, but you have the problem, right? So you might have you might be diagnosed with salmonellosis, right? You might be diagnosed with having enteritis, but we don't know how it got there. We don't know how the infectious agent got into your body. We just know it's there, right? It's idiopathic. We don't know, but we're going to treat the problem and make you feel better, make you be healthy again. But we don't know how you got it, right? Was it vector borne? Was it was it foodborne? I don't know. What could it be? Right? We don't know. Right? Idiopathic is a great word, and you're going to hear it a lot. Right? You're going to hear it a lot in your practice. And then you have nosocomial. Nosocomial means hospital acquired, and you really have to expand that out to everything that is healthcare related, right? So that could be a daycare center, it could be an assisted living, it could be a respite center, it could be a hospice center, it could be all these different things, right? And so that therefore we're trying to get away from using nosocomial because we have two other terms, and I need you to know these things, right? And they're called HAI, that's a hospital acquired infection, right? And then the other one is a CAI, and that's a community acquired infection. Because we have infections now that we see in Austin, right? Over the last 10 years or so, we've had a swim team come down with lesions on their skin due to Staph aureus. We've had a wrestling group did the same thing. We had a basketball group who came down with other type of. We had lots of different groups of individuals, right? We had a yoga studio be the foci of an infection for influenza, right? So there's just all these different things that are going on in our world, and so I want you to know those terms. The other terms, heredity, congenital, degenerative, nutritional, endocrine, and mental, those are important things also, but really outside the scope of this course. And so those 1, 2, 3, 4, those 6 terms I will ask you questions about on exam 4. Okay. So I do not get any kind of a kickback, but when I first started teaching full time, I took pharmacology because my students said it was hard, and so I took it with a group of students, and I was their tutor. I took the class, and I would help them, and I took nutrition with a group of students. I took medical terminology with a group of students because they said that's really hard. Like, so I took it. I thought I knew everything when it came to medical terminology. What I found out was I didn't know anything. And so I was so glad that I took the 2-hour medical terminology course because even though I knew a lot, I didn't know everything, and so now I have a better understanding of it. So my wish for you is that if you have an opportunity waiting to get into your program, take a medical terminology class. Your it will make your program so much easier. I think that every single person who's going into science, whether it be scientific research or going into medicine, any kind of medicine that includes nursing, that they should be required to take a medical terminology class. Okay. Yeah, yeah. I just think it's so important, and a lot of people just don't see it that way. Now I understand, right? I understand that people want to get into the work field very quickly, but it's if you take the right courses in a sequence, um, then it makes those programs so much easier, and that's what the prereqs are for. Medical terminology is not a prereq, but yeah. So yeah, and so I use these terms, a lot of them, and so if you had taken medical term prior to, then this makes so much easier. Agreed, agreed, James. I know. But I'm just saying, James, that if you are in between where you finished your prereqs and you're waiting to hear about your program and you have a semester, um, consider taking a medical term course if you can, right? I'm not I'm not saying you need to. I'm just saying it would make your life easier, right? So here's a lot of prefixes and suffixes. I'm not going to ask you about this. This is just when I like to tell people medical terminology is a good course, right? And even if you don't do that, James, go to half price books and buy a medical terminology book for about $4 and just look at it, right? You can learn a lot that way. You can be autodidactic. You can teach yourself, right? And that's a good way to do that also. Okay. Infection. So the definition of infection is the entry, the manifestation, the growth, and the proliferation, the spreading of an infectious agent within a host, right? So in order to do that, the organism must enter the host tissues, begin to grow, continue to grow in the host tissues, right? And so that is the true definition of an infection, right? It's the organism. If the organism gets in there and doesn't grow, then you're not having an infection, right? And then all the antibiotics that we looked at really stop the growth processes of those microbes, and so it halts the growth process. Therefore, it halts the infectious process, right? So if we think about these things, not only are microorganisms causing infections, but they themselves, as you remember, can cause there to be changes in in some of the cells, right? And so here you can talk about human papillomavirus can cause cervical cancer in women, but anal cancer and oral cancer in men. Helicobacter pylori has been known to be associated with gastric cancer, right? So a lot of times it is a risk factor. So if you get diagnosed with Helicobacter pylori ulcers, then your chances of developing gastric cancer go up significantly, right? Hepatitis B for liver cancer. And although a lot of these cancers, right, take a long time to develop, statistically, 2 people in our course have got cancer cells in them already, and they're developing. And so um, in 20 years, you might start to see the signs and symptoms of them. That's why we have all these things that we can do as a screening method for it, right? So we have we have a pap smear, right, which we look for dysplastic cells in the vagina and around the cervix, so that we can intervene if somebody's developing 2 people. Hmm. So typically it's about 20% of a population, right? So maybe four then, huh? Maybe four. So so typically, if we have a group of individuals, then it's about 20% of that population has some type of precancer cells, and some of us just have them in our genes, right? Mercy, what are those genes called that are in our body already? Mercy knows this because she had me for 1406, and we had a good discussion about oncogene. Mercy's made me happy today. Everybody gets 1 point on examining poo number 3 because Mercy remembered, right? That is great. Oncogenes, right? And so some of us have oncogenes just because that's what you were dealt with. You were dealt with that. You were given that when you were born, and some of us don't, and so some of us are going to develop cancer. Some of us may or may not develop cancer, right? Because we get exposed to things, and some of us will never develop cancer. Right. Well, I'm sorry, James, but it's the truth statistically. Yep. Oh, maybe you're telling Mercy thank you. Okay, that's good. Here's the infectious process, right? An organism must enter host cells, right? Uh-huh. Yeah, okay. Number 2, organism, microorganism must establish itself, begin to grow, and then it has to have a constant supply of nutrients, right? So if one of those 3 things are interfered with, you will not develop an infection, right? And so remember, I told you that control of microorganisms was really important. And if we take a look at what we did back with control, and we look at what we're talking about right now, then it all comes together and it starts to make a lot of sense about, oh, there's a reason that we talked about control. And now as we're talking about infection and we're maybe talking about some treatments, it's really going to be about doing something to control the microorganism from getting into the body, or once it's in the body, from stopping it from obtaining nutrients or stopping it from growing, right? And so that is true. Right? And there's a difference between an infection and an intoxication, right? So both of them can be caused by microbes, right? But an infection is the microorganism growing in the body, right? But an intoxication is the microorganism maybe being in the body, but maybe being in your potato salad, Nelda. And then you eat the potato salad and you ingest the toxins, and then you come down with kind of an illness. But the illness for the intoxication is usually short-lived. It can be very acute and very serious, but an infection is going to be a lot longer process, right? So if we compare just foodborne illnesses, right? If we compare those, there's a difference between those to it's an intoxication by Staph aureus and those that are infection by salmonella, right? So if we think about an intoxication for Staph aureus exposure, about 4 hours, right? From the time you get exposed to the time you develop symptoms, right? Sometimes it lasts about 24 hours, right? Sometimes less. And usually it's just about vomiting. And once you vomit, you get rid of the toxin and you feel a lot better, right? How many people have had food poisoning? Yeah, I've had it several times. And the last time I had it was at my favorite Mexican restaurant here in Oak Hill. And I ate the carnitas and I looked at my wife and I said, the carnitas are bad. I'm going to be sick. And my family was down and they wanted to go to IKEA. And she said, you're just saying that because you don't want to go to IKEA. And she was right. I hate IKEA. If you want to buy furniture that doesn't last very long and breaks easily, that's where you go, right? It's just vomit. It's not really, while the flushing mechanisms might be diarrheal also, Mercy, it's usually just vomiting. And at least the last time I had it, it was just vomiting, right? But it took me about 12 hours of being nauseated and not feeling well before I threw up. And then, well, it didn't feel like it just felt like I just felt like I wanted to throw up the whole time and I just couldn't throw up, right? That's different if you compare it to an infection by salmonella. Now these things got moved over here, and if you look at the presentation, they won't be moved over. It's just when they made it in a PDF, they got moved over. But here again, infection by salmonella, foodborne infection, right? You get exposed, and then 3 to 14 days later from the time you got exposed, you start to develop symptomology. The symptomology is cramping, it's fever. Now, guys, write this down. Bacterial infections are usually associated with fever, right? You have fever, right? Not intoxications, never. Okay. You can have diarrhea, Mercy, but you might throw up here, but not usually. It's just diarrhea, right? And fever. You can be dehydrated, and then you can have tenesmus. So tenesmus is the urge to want to defecate, but when you go, nothing happens, right? You may not even pass when. It just, nothing happens, right? And so those are the true symptoms of having an infection. Fever is the giveaway, right? And it lasts until you treat it, or then sometimes people become carriers, right? How many people have heard of Typhoid Mary? Anybody ever heard of Typhoid Mary? Yeah. So her name was Mary Mallon, and she was a very, very good pastry chef. Oh, that is that why you know? But she was a no, Mallon. Mallon. Her name was Mary Mallon. Mary Mallon. Yeah. Um. Oh. Okay. But oh my. Okay. Okay. So yeah. So she would notice that where she was working, people got sick, and so she was a carrier of typhoid fever, Salmonella typhi, and she would move on to other places, and people would get sick. And finally, the public health officials caught up with her, and they asked her. They proved that she was a carrier, and they asked her to change. They asked her to change um, her this, to change jobs, to change careers, and she wouldn't do it. So they arrested her. Um, yeah, she was yeah. Yeah. So anyway, the story of Mary Mallon, right, it lives on in infamy because it's a really good epidemiology story also to be thought about that way. Okay. When we think about the organism, right, we're really talking about what are the molecules that allow these organisms to have a competitive edge once they get in us, right? And we call those things virulence factors, right? So the virulence factors are things that will allow these organisms to colonize an area of our bodies, right? They will allow them to evade the immune system. They allow them easy entry and exit of our body, and they allow the organisms to obtain nutrients from us. So again, these characteristics of virulence factors play into the idea of the infectious process. The infectious process, remember, is organism has to get into host tissues. Number two, it has to begin to grow. And number three, it has to have a constant supply of nutrients, right? So these are playing into that strategy, right? And so there are a lot of different ways that the organisms can have that, right? They can have these structural components that we've talked about. They can have enzymes. They can have toxins, right? Or they can have things that will help them evade the immune response, right? And so there's lots of different ways to talk about these virulence factors. I am going to ask you to know them, and I'm going to make this real easy for you. I'm going to ask you to know them in 4 different categories, right? And here they are. So number one, so these are part of the architecture of the cell. They can be, for instance, mycolic acid. They can be the peptidoglycan. They can be the capsule. They can be the viral envelope, right? They can be the endospore. All these things are structural. Flagella, fimbriae, all these things, right? Number two, they can be toxins. Right? And there are lots of different toxins, but the toxins we're going to be talking about are mostly going to be bacterial toxins because those are the ones that we're more likely to come in contact with, and we'll talk about them in a minute. Number three, they can be enzymatic or enzymes. We're going to talk about some enzymes, right? Or number four, they can be an antiphagocytic property. Okay, so I want you to know those four, and then I want you to be able to think about what they are, right? So this is multiple choice. These are the 4 categories of that is correct, Barbara. That is correct. So structural, part of the cell, right? Toxin, and so we're going to talk about the toxins in a minute. Enzymes, we'll talk about the enzymes in a minute, right? And then antiphagocytic properties. These are usually proteins that do not allow um, infectious agents to be phagocytized, right, by our macrophages, right? It can also be the capsule. I mean, you could argue that the capsule is antiphagocytic, and I would say I agree, but usually we're talking about some proteins. Okay, so let's talk about toxins, right? I'm not going to talk about the structural ones. I think you're well versed in them, right? Just think about capsule, endospore, fimbriae, flagella, all these things we talked about before, right? I'm not going to talk about those. I think you know those, right? But let's talk about toxins, right? Toxins, exotoxins, and endotoxins, there's a difference, right? And so when we talk about exotoxins, these are toxins, these are toxins that are produced by the cell and released to the outside of the cell, and they all have a different mode of action. So some of them can be cytotoxins that can destroy cells. Some of them can be neurotoxins that will affect the nerves, like botulinum toxin, right? It paralyzes the nerves. And some of them can be emetic toxins that can cause people to vomit. Are you with me? Okay. The other one is an endotoxin. And so an endotoxin, if you recall, is part of the gram-negative cell wall. And so by definition, if an organism is gram-negative, it is the lipid A portion of the LPS layer that is toxin. Now, all of the endotoxin have the same mode of action, right? They, in large numbers, not just a little bit, you got to have a large one, where the exotoxin, just a little bit, will kill you, right? But with this one, with the endotoxin, you got to have a whole bunch. And if you have a whole bunch, it can cause you to lose water, or you become dehydrated or hypovolemic. You will develop fever because it's a pyretic, right? It causes fever, and then it can cause blood to clot, right? So in high numbers, this is the problem with the endotoxin. So everything that is gram negative, by definition, is endotoxic, right? That's why we have to be careful when we are dealing with an infectious agent that is endotoxic, because if we immediately have a lot of these cells in our body and we immediately move to destroy them with antibiotics, we might cause them to break up, and we've caused them to break up. Now we've made more surface area for the toxin where it's bound up in a cell. Now you've got it in pieces, and there's more surface area now to have to deal with. So we have to be careful with these organisms, right? So it's not just about knowing what they are; it's about applying, right? And science is about applying our understanding of how these organisms work, right? And so therefore we have a good way to provide a treatment for our patient. Okay, so let's differentiate them, right? So we talked about exotoxins first, right? And so you can see mainly gram-positive, gram-negative bacteria. They're metabolic products that are secreted from a cell. They're protein or short peptide. Most of them are protein by nature. They have high toxicity. A little bit is enough. 1 gram of botulinum toxin could kill hundreds of thousands of people. That's how strong this stuff is, right? It's heat. It's unstable in heat, so therefore we can denature it, right? And when we denature it, we stop it from being a toxin, but it still has the epitopes, right? So an epitope. Ooh, another cool word, epitope. An epitope are kind of the proteins on the surface of these, or the kind of the curvatures of the protein, so that we can form an antigen against it, right? So these are still have the same epitope, so we can make we can make antibodies against them, right? They have different modes of action depending on what they are. They can be cytotoxic, neurotoxin, or enterotoxins, right? They don't produce fever ever. So if you have botulism, you're not going to have a fever, right? They have strong antigenic specificity, right? So we can make antibodies against them. Hence, the vaccines against tetanus and against botulism are not against the organism, it's against a toxin. And so we make an antitox again, we make IgG against it, and we can give people that, and then it binds up the toxin and people survive, right? Same thing can be said for venom of snakes. And so one of our neighbors posted on next door yesterday that her father was, I think it was her father, a male in her life, went to get the trash can and got bit by a copperhead, right? And he was in excruciating pain, but they alleviated him from maybe losing his leg and other severe negative outcomes by giving him the antitox to it. You got to know what snake it is, though, right? Because the venoms are all different, and therefore the antitoxins will be different, right? Treatment can be using heat. That's what we do. We almost never use formaldehyde anymore, but we use heat, right? And so represented organisms with things like botulism, tetanus, gangrene, diphtheria, cholera, plague, and staphylococcal food poisoning. There it is again, right? Endotoxins, right? If we compare them, they're gram-negative bacteria. They're the portion of the LPS layer of their cell wall. It's actually the lipid A portion of it, right? They have low toxicity, but in very high number and high volumes, right? They can cause death, right? They're stable under heat, so you can't really break them apart, right? Therefore, uh, they have weak antigenic specificity. We can't really make vaccines against them, right? They cause things like fever, malaise and lethargy, shock, and blood coagulation, right? It's not feasible to make a vaccine. And some of the organisms that we talked about, like with instances with Mary Mallon, typhoid fever, tularemia, endotoxic shock, urinary tract infections, and meningococcal meningitis, right? We just have to be careful when we're treating those particular organisms. Can you all see the difference between endotoxins and exotoxins, right? They will be on the exam. Be sure you know them. Questions? Okay. Enzymes. So with enzymes, there are lots of different enzymes, right? Some of the more common ones are lipases, right? So lipases are able to break down lipids, and so people always ask me, you know, why do I get so many pimples? I'm like, well, because Staph aureus and Streptococcus pyogenes, the two causes of blemishes on the face and on the body, have a bunch of different enzymes that they can use to block the protective mechanisms of the body, right? The body produces sebum and oleic acid and a bunch of other things that are supposed to protect us from bacteria, but these bacteria have the ability to break down those fatty acids that are protecting us, right? And therefore they can cause pimples, right? And so we should wash our faces, but we should not use astringents on our faces, because by using astringents, what you're doing is you're removing the natural barriers, the natural chemical barriers that your body is putting on to protect yourself from these organisms, right? And so if you do that, then you're just asking for trouble. And loofahs are a no-no, right? If you're using loofahs to exfoliate your skin, loofahs are just a house of bacteria. And so if you're cutting your skin and you have bacteria that live in that loofah, they're going to get into your body and potentially could cause a, a bunch of pimples, right? Men, on the other hand, a dull razor will do the same thing. So you want to be sure that when you're shaving your face, if you shave your face, that you're using a sharp razor so that there won't be any small nicks or cuts that the dull razor leaves behind, and then microorganisms can move in that way and cause problems, right? Yeah. You might have heard me talk about coagulase. Coagulase is an enzyme that some organisms have. Staph aureus is notorious. But what it does is it forms a fibrin network around it, a clot. And so you can see it right here. There's a clot around it. And then the bacterium grows in there and it spreads out radially from there, right? And then you have this abscess get bigger and bigger, forming a boil or whatever, right? And so, yeah, it can be problematic. And the other one that's important is hyaluronidase, right? So for those of you who've taken Anatomy and Physiology 1, what is hyaluronic acid? What is hyaluronic acid? Mr. James, what is hyaluronic acid? Mercy, I'd pick on you, but you're taking it right now. Um, okay, that's all right. Anybody? Anybody? Justin, Jordan. I have a bunch of J's. Jamie. Yeah. It does, but all tissues, it really is what holds all the cells together, right? It's, if you will, it's the cement of the cells. So hyaluronidase really kind of breaks up that stuff, that hyaluronic acid. And for those of you all who might buy beauty products, it's in a lot of beauty products, right? It's, if you watch Eva Longoria on the television, she says hyaluronic acid adds to the yeah. Well, it can be, but the problem is it doesn't necessarily get into the skin from outside, right? But either way, it holds the tissues together. But hyaluronidase gets in there, and you can see it right here. It's kind of small, the wording, but it's getting in there and it's opening up the area around the cells, and therefore you can see the bacteria can get into the tissues, and then it can cause an infection, right? Hyaluronidase is known as a spread factor because it destroys the, the cement, if you will, the glue of the cells. And so therefore these organisms that produce hyaluronidase, and they're all flesh eaters, right? Streptococcus pyogenes, Staphylococcus aureus, Fibrio vulnific, there's a bunch of them, but they can spread in the body very quickly. because they produce this enzyme called hyaluronidase, and hyaluronidase is known as a spread factor because of that. Okay? Questions? All right. So, um, so we talked about, I didn't talk about structural, right? Um, we talked about toxins, we talked about enzymes. And I want to make mention of the two, I don't have a slide for it. I didn't put one in, but I wanted to make mention of the two antiphagocytic properties, right? So the antiphagocytic. Yeah, I think that'll do. Oh, do you want another one? I can give you some more if you want, but those are the only three. How about that, Barbara? Okay. The the two antiphagocytic properties besides a cap, I'm going to put capsule in there because it can prevent phagocytosis, right? But the two that are most interested is Staph aureus produces what we call protein A, right? Oops, protein A, and Streptococcus pyogenes produces M protein. Now you might say, oh, that's supposed to be a capital M. You might say, Provine, why are they M protein and protein A? Well, because scientists have big egos, and when they are working to look at the research about what's doing what, right? They want to name things and they don't want to follow each other because then that gives validity that the other group, is more important. So they do it their own way. So protein A is produced by Staph aureus, and M protein is produced by Streptococcus pyogenes. Both of these do not allow the phagocytes to ingest the cells, to engulf the cells, right? They keep them away, right? And so these are important things to understand. And that's all I'm going to say about these two things. That's all you need to know. Okay? Questions? I wanted to make mention of them because they are a little bit different in the way they function, right? And so I made it easy for you guys to know the virulence factors in four categories, right? Structural, toxicological, enzymatic, and antiphagocytic, right? And so if you just remember those are the easiest way to remember those. Okay? Questions? All right. So now, so those are all the advantages that the microbes have against us, but our bodies are remarkable. And so we almost never get sick. And the reason we don't get sick is because we have lots of different ways. Oh, Angeles, they don't allow for phagocytosis. So it's antiphagocytic, right? So they don't allow for the cells to be phagocytized. Okay? Okay. So, remarkable body. We have lots of different mechanisms by which we can be protected, right? And so we're going to be talking about these things, right? So we're going to be talking about innate mechanisms first, right? And so that's mostly going to be physical, chemical. I'm not going to do too much with genetic components, right? And then we're going to look at the second line of defense, which are going to be interference, phagocytosis, complement. And then we're going to be looking at the third line of defense, which is immunity, because we form immunoglobulins, right? So these that we're going to talk about today, or at least start, we may not finish, are called what we call the innate immune processes. These are going to be acquired, sometimes referred to as adaptive immunological responses, right? And that's going to be our natural and our artificial acquired immunity over the entire lifespan of our year. These we are born with. Yeah, some of them get better over time, right? But the other guys over here in the third line of defense, we acquire throughout our life. Okay. So this is a really great little chart that probably you should be familiar with because it really lays everything out pretty easily. Okay. So let's talk about some of those innate processes, right? And so these are things that are non-specific defenses of our body and allow us to be protected against all these invading pathogens that are attacking us all the time, right? And so there are all the things that are part of our body, the skin, the mucous membranes, everything, right? And so we look first at our non-specific physical barriers. This is the skin and the mucous membranes, right? They're great barriers, right? And as long as the skin is intact and as long as you're producing mucus, you are blocking a lot of organisms from getting into your body and they're not going to cause problems, right? The skin is a beautiful barrier. As long as there's no breaks or breach in the skin, you're protected, right? So this weekend I was in Bastrop doing work, and my tractor broke. It's a lawn tractor, it's not a real tractor, but I had to fix it. And when I laid down to fix it, I got up real quick. And when I got up real quick, I put my hand off to push off, and I put it on a pine cone, and the pine cone cut me, right? And so I'm like, oh heck! But I didn't do anything, and so it's okay. But you know, you can get cut just about doing what you think is just normal kinds of things, right? But you just have to mitigate risk, right? Skin and mucous membranes really important, right? So here you can see a lot of different things that are produced by the body that are protective, right? The sebaceous glands produce all kinds of really cool sebum and oleic acid and things like that. The tears themselves have an enzyme in it called lysozyme, and that lysozyme breaks down cell walls. The mucus itself is it can bind up things, and you can either hack it up or blow your nose, get rid of it. Saliva has lysozyme in it, right? The skin is intact, right? The cerumen, the earwax that we produce is protective, right? Um, and the low pH of the skin, right? Stomach acids, right? Intestinal enzymes and mucus, right? The sweat, right? The sweat itself has electrolytes in it, makes it a little bit hypertonic. And so only certain organisms can survive on our skin. And therefore, we have these other processes that we do, right? Um, Defecation and urination, which allow for the flushing of our bodies, right? And so that brings us to flushing mechanisms, right? You might not think of these as defense mechanisms, but they are, right? Sneezing, coughing, lacrimation, which is the tearing up, right? Tears. One of the first things that happens if you're mowing the yard and something flies in your eye, one of the first thing that happens is you tear up considerably, right? And that's a mechanism to protect your eye. Right? Number one, it coats the eye so it doesn't get scratched. And then what's supposed to happen is whatever the foreign object is in your eye, if it's light enough, it will be picked up by the hydrostatic effects of the fluid, the water, and it gets to the kind of the crux of your eye, and then you can just kind of pull it out that way, right? So these are all mechanisms, right? Sweating, the formation of earwax, um, salivation, right? Defecation, and really even peristaltis, which is the movement of foodstuff, and a bolus of food um, through your digestive tract and eventually of your out of your anus, right? And so that's all important. Okay, questions? Right. So here is the mucus escalator. I had not talked about the mucus escalator, but it's the ciliated cells in the trachea and the lungs. As they get stuff that's in them, because it's an open system, and you breathe stuff in, you get stuff into your lungs, and the mucus escalator moves them up from the lungs. They get into the trachea, and then the ciliated cells of the trachea kind of move them up to the back of the throat, and you get a little tickle back there, and you cough, and out comes the stuff that was in your lungs. And so that happens when you have a cold, right? As you're getting through or toward the end of the infection of either having a respiratory tract infection or a sinus infection, your mucus at the end becomes more thick because it's got more debris in it, and it's got white blood cells, and the white blood cells have gotten into your sinuses or into your lungs through diapedesis. Who knows what that word means, diapedesis? Diapedesis. Who knows what that is? Miss Nelda. You took medical term. What is diapedesis? Okay. Diapedesis is the movement of white blood cells out of the circulatory system and into the tissues. And you want that to happen because that's the way it fights infection. Okay. Diapedesis. Be sure you know that term. Diapedesis. Okay. Oops. But you should know how it's spelled correctly. It's not a Y, it's an I. Diapedesis. Questions? All right. Non-specific chemical defenses. These are the sebaceous secretions that are oleic acid and sebum, like that. The last is tears, lactic acid, and electrolyte concentrations of your sweat, the skin's acidic pH, and fatty acid, right? The hydrochloric acid in the stomach, right? Digestive juices in the bile and the intestines. Even the semen has antimicrobial chemicals in it so that it doesn't the sperm don't get destroyed by the bacteria. And then the acidic pH in the vagina, right? Hence, you should never alter the environment of the vagina unless it's medically necessary, because if you disrupt the population of the vagina, then you're more apt to have an infection of that area, right? Complement. I'm going to give you a real quick. Little definition of that. Complement is a series of proteins that are initiated through a cascade, right? And so what that means is, think of a sparkler, right? So when you light the sparkler on, you see all these little all these little kind of sparks all over the place, right? That's essentially how complement works, right? So complement is initiation. The complement sequence is initiated by one protein becoming excited right here, right? And then it excites two others, and then a bunch of others, and then eventually you have this cascading particles all get initiated all at once. And so you have all of these proteins can come in and help to fight the infection. Complement has the ability to neutralize viruses, enhance phagocytosis. It can damage the cell because it destroys the plasma membrane, or it can help to just break apart the cell completely, lyse the cell, right? That's the definition that I want you to know. Um, and that's it, right? This complement is so important and so um, complicated, that I'm just going to basically say, for this course, you just need to know that that's the way it works. There are other pathways, right? Classical, lecithin, and alternate. If we were in the classroom, I would have you do an activity with complement, but we're just not. We don't have time, so we're just not. I'm going to leave it there. Okay, as a cascade of proteins that can neutralize viruses, it can destroy microorganisms, it can enhance phagocytosis, and we'll just leave it there. Okay. All right. Interferons. Interferons are produced by every single cell in the body in a little bitty amount, right? They have um, they have anti-cancer properties and antiviral properties, right? And they interfere with the transcription and the translation of messenger RNA. And again, interferons are important. We also have some interferons that are made, or they are collected from pools of a bunch of people, and then they're sold for people who are fighting MS and other types of infections. And so these are called things like beta seron. There's a bunch of them out there, but beta seron is kind of the one I know the most, right? Because one of my friends has MS, and so anytime she has an episode, she takes an injection of beta seron. Okay. So that brings us to non-specific biological barriers, and so these are the microbiota of the body, right? They are the normal inhabitants of the body, either commensalistic or mutualistic, and so what you have is you have these organisms that can outcompete potential pathogens for space and nutrients, and so because they are more adapted to our body, then the pathogens are less likely to um, become established and cause infection. And then you have the natural resistance that you develop throughout your entire life, right? Um, so we're going to be talking about that when we talk about adaptive immunity, um, next time we meet, right? Because we're going to be looking at the immune response, right? We're going to be looking at the at the properties of the white blood cells, right, and how the immune system works. So as we get into that, right, we think about immunology as being the study of all of the features of the body's second and third line defenses, right? And so we're not only we're mostly it's phagocytosis. We'll be talking about phagocytosis here. And a healthy immune system is going to do several things for us. It's going to be responsible for surveying the body. It's going to be responsible for recognition of foreign material, not what we call non-self or an antigen, right? So non-self, also known as an antigen. Right? These are things that are not part of the body, and we're going to be talking about those, right? And then it either sequesters or destroys those things that the immune system decides is not part of the body, right? And so if we think about this, then again, think about those markers, right? Those epitopes, those things that are on the surface of the cells. And every one of the cells that are in Angelis's body are marked Angelis, right? Every one of them, except the red blood cells. The red blood cells have a different marking system, and that's good because now we can transfuse blood as long as we cross type and match. But everything in James' body is marked James. Everything in Abdullah's body is marked Abdullah. Everything in um, Jacqueline's body's marked Jacqueline, and everything in my body's marked me, right? And so because of that, if we have a transplant, let's say James and I are good buddies, and James decides to give me a kidney, well, we're good cross type and match. If he gives me a kidney, then my body's still going to reject it because his kidney is going to be marked James, and my body is looking for things that are marked Felix, and therefore I have to take immunosuppressants for the rest of my life um, in order to be able to live with the James functioning kidney in me, right? And a lot of people don't know that, but that is true. Here's a really good illustration showing the white blood cells, right, coming in contact with cells that are marked us, and so it just leaves them alone, and they go on their merry way. Here's the white blood cell coming in contact with the structure that it doesn't have our markers, and so it recognizes it as being not part of us, so it phagocytizes it. It then destroys it completely, and these things can be destroyed. And it's a lot more complicated than that, and we're going to be talking about that next time, right? We're going to be looking at the responsibilities of what we call the beta lymphocytes and the T lymphocytes, right? And so we think of these as being humoral immunity and also being um, cell-mediated immunity, right? So this is humoral and this is cell-mediated, and we're going to be talking about those next time. Okay? Any questions about anything we covered today?